Thank you all for joining us today for another episode of our podcast, Moving to Value Unscripted. My name is Dr. John Rodas, and I'm a recovering ex-hospital president and am proud to be the president of the Moving to Value Alliance. The Moving to Value Alliance, MTVA, a 501c3 nonprofit, is a multi-stakeholder grassroots organization whose purpose is to foster a community that aims to create a value-based healthcare ecosystem with high-quality outcomes at a reasonable cost for plan sponsors and their members, beneficiaries, or employees. I want to thank our members whose support makes this podcast possible. We'd like to give special recognition today to our trade member, Hartford Healthcare. I'm joined by my fellow board members, Dr. Steve Schutzer and Dr. Brian Klepper. Steve, a nationally renowned arthroplasty surgeon, is one of the founders of MTVA and is a co-founder of Upswing Health. Brian, a nationally recognized healthcare analyst, commentator, and strategist, serves as Chief Strategy Officer of the Employers Clinic Commission. Brian previously joined MTVA Unscripted to discuss incentives in retail healthcare, and this is the first time with us as a host. Welcome, Brian. We're thrilled to have you on board. Our special guest today is Brock Slabach, Chief Operations Officer for the National Rural Health Association. Brock was a rural hospital administrator for more than 20 years in Ohio, West Virginia, Pennsylvania, and Mississippi. He started with the National Rural Health Association in 2008. He specializes in developing rural health systems that encompass population health and the varied payment programs moving rural health providers into value-based purchasing models. Brock joins us today to discuss the status of healthcare in rural regions across the country, the challenges and opportunities of recent and upcoming federal funding impacts, and the shift from fee-for-service to value-based models that can best meet the needs of rural communities. Welcome to Moving to Value Unscripted, Brock.
Thank you. It's great to be here, John, and appreciate the opportunity.
Let me just start by saying that most of us are city slickers, so my idea of rural health is like New Jersey because I grew up in New York. So I have to admit I know little about rural health, and I was a city hospital administrator, and unlike you, could you maybe give our listeners a little bit of a picture of what rural health is, and also along the way weave in your journey as a rural health administrator and now with the National Rural Health Association.
I think that it's first to set the context. 80% of our land mass in the United States is covered in rural areas. About 20% of the population lives there. And so by definition, we have very sparse populations, very low volumes that our providers are experiencing. I think it's important to recognize that our rural populations are desperately in need of healthcare, just like we have in the city. And the reason for that is that these individuals produce all the food, fuel, and fiber that power our country. And we need to have good quality healthcare local to where these individuals live and work to keep us, those living in urban areas, fed, clothed, and with energy. And so this becomes an exchange. We look at this as kind of an exchange in terms of public policy, keeping these areas with good quality healthcare. So when we look at rural healthcare, as I mentioned, it has what I call the tyranny of low volume. It's difficult to spread out a fixed cost of operation over a small number of units. And so that by definition means your unit cost is higher. And what's happened over the last several decades is that we've rewarded systems of care that have volume as one of its predicates. And so we have to figure out a way in our rural systems to solve for that. So when I started my career in healthcare as a hospital administrator, dealing with these very issues, I learned very quickly about how to manage in the fee-for-service system. So even in a rural context, you could look at service lines that would make you money. You can focus on those and you can develop it. Unfortunately, though, I have a degree in public health, and so I found myself for 20 years in rural Mississippi doing quite a bit that was service line development, but it didn't do much to improve the health of the population. That was kind of the conundrum that we faced in terms of rural healthcare is doing the things that benefited our payment structure, but not necessarily what benefited our population. So my career journey led to this hospital in Southwest Mississippi beautiful location, great medical staff, awesome board. And we worked together for 20 years to help these communities in 2 counties to survive and to thrive. So I take that experience to NRHA, where I'm at now, and trying to figure out ways in which we can apply some of that anecdotal learning to a larger context in terms of value-based care and moving patients and communities into that space.
Hey, Brock, just along those lines, I too did a little bit of reading about your background, and you make it clear that rural hospitals shouldn't be a mini urban setting, that there are key differences, right? That it's not just a question of taking a St. Francis or a Hartford hospital and shrinking it down. What do you think would be the best fit then for a rural hospital?
I think we have a pretty good array of services, I think, in rural areas. And I think we need to just really focus on how we can incentivize the reimbursement structures to do two things. One, keep these facilities open as a matter of survival. And then second, how do we incentivize payment structures to allow the community, and I stress the word community here, this isn't just the hospital, it's the community, in terms of coming together and understanding the incentive structures and how those incentive structures can be changed to do an important thing, and that is moving into services and programs that will actually improve population health. For example, chronic disease management, care across the continuum, moving into care management as a strategy. But at the same time, that can reduce your admissions in the hospital over time, which then puts the hospital at jeopardy because it's no longer able to support that infrastructure I talked about earlier. So we have to intervene into that vicious circle. We know what we need to do, but it's just what we need to do is not going to help us to keep our hospitals open. So we need to have some transitional point where we can implement strategies to maybe help with that.
None of us hospital administrators, at the end of the day, I don't know why we call it healthcare. We call it's sick care. That's
Yeah.
what we do in hospitals. So I think your point is really at the essence of the problem, right? It's payment reform. So if it's everybody talks about having a vertically integrated system, and many big hospital systems actually do, right? They have all the providers, they have clinics, they have hospitals, they have ambulatory surgery centers, but most of the profit margin still comes from those high-end services, the hip and knee replacements, the spine surgeries, the cardiac surgery. And we hospital administrator types, are focused on driving that volume, as opposed to your point of how about we prevent chronic disease in the first place, which then, of course, kills our margins. We're in the middle of a government shutdown right now. How does the, recent big, beautiful bill and the government shutdown particularly affect the rural health care in this country?
Well, that's a big question. Obviously, we spent a long time since the passage of the Affordable Care Act in 2010, increasing the number of people that have insurance in this country. So our uninsurance rate has been up until now, the lowest it's been probably in history. Unfortunately, though, some of the measures in the One Big Beautiful Bill Act will reduce coverage for a large number of people, particularly those on Medicaid. That seemed to be the focus of over $1 trillion in estimated reductions by the Congressional Budget Office to Medicaid outlays. That came in a couple of different forms. First is basically recertification and work requirements to be implemented as a part of recertification into the program. The second piece was reductions in the payments through provider taxes, which is an really important program for rural hospitals. This is probably the one that keeps a lot of them open. And then the third bigger piece is the state directed payments. These are essentially ways in which states have helped to fortify Medicaid funding to rural hospitals and large urban hospitals as well through Medicaid payments that would be higher than normal. And so those are the three big areas. There's a number of things that are smaller. The other thing that it did is it created the Rural Health Transformation Program, which is getting a lot of attention now because we're in the middle of the application process that the states are going through. And so this is that $50 billion program that's going to be allocated to all states that apply. And that will be potentially a source of money that can be used to what I talked about earlier, looking at how we can change incentive systems to move our structures into a more progressive or a more future thinking way of providing care that doesn't at the same time destroy infrastructure of rural healthcare. And so I think that's going to be that'll be a challenge, and I can go into why that's a challenge, but I think that we're excited about the offering of this money for that purpose going forward.
Hey, Brock, and you made a comment before that I thought was very interesting. 80% of our country, the landmass is rural, and 20% of our population lives in that. But I hadn't actually thought how dependent the other 80% is on the success of that 20%. That's a profound statement I've never really processed, and I think it should be amplified. I've been thinking about our conversation a few weeks ago and how volume is not going to drive success. Technology is too expensive. I'm a joint replacement surgeon. That's not going to drive. And I'm thinking about what would make it work. And, I've had some interaction with medical students recently, and they're young kids. They're in their 20s. I've been very impressed to how different their worldview is.
Hmm.
Again, maybe I'm being optimistic, but not really driven by the same thing that may have driven me and John. I mean, I see them finding a very nice life in rural America.
Hmm.
Is that just a pipe dream, or do you think that the younger kids may see it that way?
Well, that's an interesting point, Steve. I share your sentiment. I think that there's an attraction to rural practice that I think is healthy and refreshing. It rather started in the pandemic. There was a lot of individuals that were stressed out because of their difficulty living in a large urban center during just a really awful experience, and they found moving to the country, if you will, was really what they found to be helpful in that situation. So we saw some migration of practitioners go to rural areas as part of that process. And then also, I think we have a lot of hospital administrators around the country in rural areas that are looking at kind of a missionary spirit, looking
Yeah.
for those that really want to make a difference, not just be a cog in the wheel of a big, large multi-specialty practice, making a production along a line of services that's going to probably make them good money and then probably more importantly make their practice a lot of money, and they didn't want to be caught up in that. So yes, there's a real attraction to leaders in hospitals that are looking to that cohort of medical student and young residents that have that in mind. And I would encourage any person training to look a couple of things. One, look for a rural training track. We have a large amount of funding that's being provided through the federal government to do residencies, or at least partial residencies, in a rural area through this rural training track program. That will give you an exposure to what it's like being in a rural community. And then second, take a look at rural as an option in terms of thinking about your practice opportunities. I think that would be an exciting option to take a look at. And I know there's a lot of rural hospitals that's out there and administrators that are excited to talk with folks like that.
I just want a quick follow-up. One thing I have noticed amongst these young people is that while they're not as driven for economics, it's lifestyle. The challenge in rural health would be they couldn't be the only horse in town. They would need some sort of
Yeah.
support. I think about myself. I became a subspecialist in orthopedics, but I enjoyed setting bones and putting on plaster. And I don't know, John, what do you think? Go back and do it again?
It strikes me that optimistic scenarios are a little bit unrealistic at this time. There's going to be tremendous competition for the resources that you're talking about. The $50 billion that you mentioned, that's nothing. That's breakfast. And I think in the competitive market of suitors for the dollars that are available out there, rural health is going to come in relatively weak compared to the other players that are out there. I think that one of the things that is going to happen is that the traditional fee-for-service model is not going to be productive for the hospitals, but the movement to advanced primary care that is independent from the health system and that is tied into virtual care and high-performing specialty services all all through the continuum, all that sort of thing. That's going to be very important, which means basically, I think what I'm trying to get at is that it seems to me that rural hospitals have to be smarter than they've been in the past and smarter than the people in the urban sectors. They're going to have to make more with less, and they're going to have to court the manufacturers and other business leaders in their communities to be actively engaged in the health of the community.
Yeah, that's a great point, Brian. In some of my presentations, I'll be able to venture into thought about a future for rural hospitals, and not just hospitals, but administrators that run these facilities. And it's my contention, and I think that it's being confirmed, is that the hospital administrator in rural hospitals in the future is going to be more of a community organizer than a institutional manager. And
Great point.
that there
Yeah.
needs to be a more collaborative approach among all stakeholders that have responsibilities and accountabilities for healthcare to come together and not try to compete with each other, but to cooperate to see how they can tackle tough problems in their communities on their own. Because I don't think that the solutions to solve some of the problems that we have in our rural areas are going to come outside of rural areas. It's going to be the people in those communities coming together for that kind of work. And I think the skill set that we train future hospital administrators on may be a little bit different in that regard, so that we can foster some of the things you're talking about, Brian. The other thing is that we have an incredible complex system of reimbursement in this country, especially in rural. If you look at the alphabet soup of the payment programs that we have, what we've done over the years since the prospective payment system was implemented in 1983 is we've simply added on little patches and fixes to try to keep us a little bit more in business than we would have if we hadn't had that. So we are constantly trying to cobble together this the structure that helps keep our hospitals surviving. During this shutdown that we're in, and hopefully it'll be over soon, some important rural Medicare payment programs have expired on September 30th. The Medicare Dependent Hospital Program, the Low Volume Hospital Program, the Rural Ambulance Add-on, which is a 10% add-on for rural ambulances that make runs in their communities, which is an important element to help them keep that important service going. So we're constantly facing these, I guess I'll say, these episodic sorts of crises that affect our payment programs. So that's what I'm hopeful that the $50 billion can do. I agree completely. It is a drop in the bucket. They estimate that the $50 billion is a third of the cuts that are going to go directed to rural facilities as a result of the One Big Beautiful Bill. That's $137 billion is what the Kaiser Family Foundation estimated will be the loss as a result of the measures in the One Big Beautiful Bill Act. So this is a down payment, I guess you could call it. But what I hope that it can do is produce some of the infrastructure around some change that could move reimbursement systems to something different. So let me just give you a quick example. That's the Pennsylvania Rural Health Model. They got a grant of $25 million from the Center for Medicare and Medicaid Innovation back in 2018 to implement this global budget program for rural hospitals. And we ended that last year, the end of 2024. And it was, I think, very successful, especially given the fact that we had the pandemic right in the middle of the demonstration. So this was just a really unfortunate set of timing for that. CMMI chose not to extend the program because they said it was too expensive and didn't yield enough result. I would tell you, though, that there were 18 hospitals in the program, and all 18 in rural hospitals in a survey said that they would like to continue the program, especially if there were some positive changes in another round. So this global budget was a multi-payer alignment system. So it included Medicare, Medicaid, 2 or 3 commercial companies, including Medicare Advantage, and they all coalesced around this one payment mechanism for rural hospitals that joined the program. And it was successful, in my opinion. And I think that that's the kind of energy, that 25 million is what I'm getting at. That seed money of $25 million to generate that infrastructure, the back office needed to run that program, was all it took work. Now, each state for 5 years, starting in 2026, will get approximately, depending on how rural you are, $200 million a year. So if you took 25 million of that and did a program like that in a rural state, you could have some wonderful experimentation around value-based care and programming to create something that maybe works, and maybe it doesn't work, but at least we're trying to implement something that's useful looking ahead to the future.
So is that a little similar to the Maryland kind of project, so to speak, where you're getting a payment where, you don't know, instead of all the bureaucracy that goes with submitting claims and getting paid and getting denied and all of that, which is a tremendous cost for anybody in the
Yeah.
healthcare business and particularly hospitals. Hey, we'll pay you what we paid you last year collectively. We all agreed, you manage it. And then, you can eliminate all of that back office stuff and actually start investing in the community, investing in prevention, investing in your clinics. We're talking a lot about hospitals, but
Yeah.
hospitals really aren't what we're talking about with rural health, right? It's federally qualified health centers, it's clinics, it's family physicians out there and small practices. And the focus really is, to your point, keep them healthy, keep them out of the hospital. And if you could shift those monies towards that, educating people about food and nutrition and exercise and stress management and sleep, and maybe help us describe your population a little bit. But I think the population is probably older and poorer and sicker and smokes
Got it.
more. And, the social determinants and inequities are probably profound in that population. Some of them probably don't even have high speed internet. So if you could start shifting, the hospitals need to be there. Okay, if you have a heart attack at 3 in the morning, somebody needs to be there to stabilize you and maybe ship you somewhere for an angioplasty. If you're going to have a baby, honestly, I'm not sure every small little community hospital should
Yeah.
do obstetrics. I'm an obstetrician. It's, you have obstetricians, you need ultrasounds, you need people to do prenatal care. But then when you have the baby, which is a one-off event, go to someplace, right? Am I off base? Is that kind of the idea?
No, you've beautifully enunciated a lot of the issues that we face in terms of providing services around our hospitals. I agree. Hospitals are not always the answer to every problem in terms of rural healthcare. But what's happened over the last couple of decades because of the economics of medicine is, and it's happened in the urban areas too, is that rural hospitals have taken over most, if not all, of the practices in their communities. So now the hospitals own the primary care and other outlets for service that the provider community is making. And so if the hospital closes, you've effectively terminated the employment for your entire primary care workforce. So this is why hospitals are kind of central in the organizing principle of a rural community's health. And so then you got that outlet there in terms of that. And I agree completely. Federally qualified health centers, free clinics, there's some free clinics in many of our rural communities that are run by physicians that are retired that want to give back a service. Again, it's coalescing those stakeholders in the community around some mutual goals. So there's two features to the Pennsylvania rural health model. I didn't get to the second one, but I think it's a great place to insert it. To your point, is in addition to the global budget, which is a way to level out your funding, your cash flow. The second piece that was equally important was each hospital had to write a rural health transformation plan. And it had to outline how they were going to move away from the fee-for-service model to more of these programs that are going to be more outpatient focused. Go to a model of hospital without walls, maybe as a way to say it. How do you transition that? But the good news for the hospital is they're going to still continue to get that level of funding while they do all of these community-based programs so that they're not going to put the hospital out of business. So you mentioned Maryland, great example. The Maryland program is complete, I think, completely different than the Pennsylvania rural health model. The Medicare system in Maryland is completely different. It's an all-payer system that's run by the state, and Medicare doesn't even operate the same in Maryland as it does in all other 49 states. So it's a different element, although there is that global budget element, which has been helpful to rural hospitals. I went to a Maryland meeting, it may not be true anymore, but they were negotiating the continuation of the global budget model in Maryland, and the legislature was debating the bills and such. And I asked, would you want to go back to traditional Medicare? I mean, if they didn't get this passed, then they would essentially go back to traditional Medicare. All these rural hospitals would have to become critical access hospitals. The unanimity of the group was, oh no, we wouldn't want to go back to that. So I guess for all of the frailty of that system, that we think about in terms of the operation of it, all the issues, it still was better than what the alternative was. And I think sometimes you have to focus on that.
Yeah. Brock, I want to go back to Brian's earlier question and your response, which I find very interesting about independence. And I'm trying to put myself in the seat of a rural health administrator. Who are you going to trust? You can't trust the government, unfortunately, with all
Yeah.
good intention or not. It changes every 4 years. I mean, you adapt and you try to make do with, and then the next thing is gone. And I'm thinking about city hospitals absorbing some of the rural hospitals. I'm not sure that's been so great. They tend to siphon off some of the better quality and leave them hanging out to dry. So the answer, once again, seems to be independence and innovation and independent thinking, and which I like. And a couple of months ago, I was at the Rosetta Fest. It's a big national movement. At its core is direct primary care. It's really a love fest for folks who want to innovate and change. But we learned about these models called community old health plans. You kind of suggested something like that, where healthcare is like fire, police, ambulance, right? I mean, but it's an independent entity that can do direct contracting. Is that something you're thinking that it might coalesce into a model like that?
Yes, the language that I've used in this space is the community care organization, or a CCO. It could be a corporation that's formed among multiple providers to help do single signature contracting around an array of services, not just those that are in the hospital. It's a way to move incentives around reimbursement so that it's consistent across multiple providers in the system. Unfortunately, again, that's an infrastructure that takes money and time and effort, and many rural facilities don't have. I mean, one of the things I talk about, and because I experienced it at my hospital in Mississippi, was we're a mile wide and an inch deep in terms of leadership. I had 18 department heads, and then I was the CEO, and I didn't have like 2 or 3 or 4 vice presidents to go off and do strategic initiatives and develop all of these programming ideas. And so we would be limited in that ability. So one of the things that the Rural Health Transformation Program that was in the Big Beautiful Bill could help set up some of the infrastructure and staffing for some of these back office programs that could help to what you're talking about. The other movement that's really catching wind, it's an old movement, but it's just kind of being reinvigorated now. That's rural health networks, mostly hospital networks. And what we like to feature with this is independence through interdependence, rather than having to assume that all hospitals eventually are going to be part of a system, a tertiary healthcare system with a hub and spoke. What if you had a horizontally integrated network of hospitals and perhaps other providers in a collaborative that can, one, seek efficiencies through maybe combined services, like, have one laundry, or have one, you could develop a chronic care management program among 5 hospitals in a region, and then have leadership that's provided at the network level versus having every hospital hiring an individual of that type and having high cost. The other thing that I'll say from a value-based care perspective is that we're seeing networks now moving into the clinical and financially integrated network model. So they're integrating clinically and financially to be able to do, as there are in North Dakota, the network of 28 hospitals there have just moved to be able to do single signature contracting for managed care. And so they're using the leverage of a larger group now to negotiate with managed care company to be able to hopefully extract better recognition of the low volume issues I was talking about earlier, and hopefully move into the space of being able to get better reimbursement from those payers.
In Indiana, there's a broker who has focused on worksite primary care clinics and is networking those around the state of Indiana so that they can move patients into any of them and get the same result. So there's a lot of standardization involved in that. And that goes back to what Steve said about independence. I wonder, when the docs get bought up by the hospitals, does the hospital go and say, we expect referrals in early and often on the following services? But also you have inherent competition against the small hospital companies, or sometimes the large hospital companies and other organizations. I guess the big one that comes to mind is dialysis, which is spread out all through the rural world. How do we get beyond that?
Yeah, I think regionalization is an important tool for us looking ahead. And I think for rural hospitals, even more so. Again, looking at networks, one of the things I keep hearing about an awful lot, I'm afraid I don't understand very well yet, but artificial intelligence is another tool that we have to maybe accelerate some of the productivity in healthcare. Although I'm old enough now to remember all of the different things coming out that we're going to increase the work, increase the satisfaction of physicians and other practitioners and decrease their workload. And
Yeah, still waiting for those.
we're still waiting for that nirvana. But I think artificial intelligence could have some real possibility in this space, and I'm hearing even rural facilities that have certain EHR vendors that are starting to use this in their primary care space to do with their documentation and really improve not only the documentation content, but also do it in a much quicker fashion, which then enhances their productivity around patient care. So I think that we have to be open to all of that. I think this regional network idea could be an excellent vehicle for that, because again, each small rural node in a network can't do that on their own. And I'll just be frank, large urban systems now are stressed financially as well. I mean, the reality is if you're a hospital in a rural area that's not currently part of a system, it's probably going to be increasingly harder to be that, because urban systems are just not interested in risk any longer.
That's a great point.
Going forward. And so rural hospitals are going to be on their own. In other words, they can't look for someone to come in and save them like maybe they did 10 years, 15 years ago. So I think we have to be clever, like you're saying, Brian, around all of these modalities to be successful going into the future.
Yeah, I like that
Yeah.
regional health network idea of those multiple smaller hospitals. I mean, there are examples of systems that have purchased small community hospitals, to your point,
Mhm.
under 100-bed ones, and invested in them. And as you said, removed a lot of that back office stuff through consolidation, and they're still going to reap the benefits because it is the kind of that spoken hub model. If they do it that way, it could work. But in places where that's, like to your point, where that's not happening, it's probably not going to happen. You're right. I think hospitals, the appetite for further growth and acquiring, especially small hospitals, I think is waning. Putting them together to create those networks really makes a lot of sense.
One of the great parts of my work is discovering bright spots and then replicating those and getting that word out so that others can imitate some of those wonderful programs that are valuable, I think, to this space. And I think that learning is really critical in this stage. And we've got, I think, smaller nodes of that all over the country. I mean, in Washington State, there's a hospital that's doing food as medicine, and they've contracted directly with payers to provide services, and then more importantly, create clinical quality programs that would be unified across different payers so that there's not multiple programs around data reporting, which then creates another huge burden on small hospitals. Every payer wants a different set of data.
Good point.
Well, time has gone fast, Brock. And, it's very interesting that I would say all of our guests that we've had on, although there's a lot of bad things going on in healthcare, rural or urban, it's not a good time for healthcare. But it's interesting how the conversation always gravitates to solutions. And I think that's the kind of wiring of the folks on our board and our guests. We can mire about the BBB and forever. That's not going to solve the problem, right? But it's just very interesting to me how the conversations always gravitate to inspirational messages and optimism. And we do have a tradition on the Unscripted podcast, and we've touched on it a little bit. But if you had to put on your blue sky thinking, and we usually say 3 to 5 years, but maybe 1 to 3 years. Where do you see this going? How will technology play out? APRNs? What are you thinking? How this is going to actually come together?
I'm optimistic. I think that with great crisis can come great opportunity, and looking at these as ways to think outside of the box to change the dynamics around which we tend to operate. And so I'm looking at the Rural Health Transformation Program to jumpstart perhaps some innovation around the country that we wouldn't have had otherwise. The states are going to be driving this, which I'm equally excited about. This isn't going to be a federally driven, it'll be a federally funded, but won't be a federally driven program. So each state will have 5 years to basically implement laboratories of experimentation around transformation. And I think some states have got some really good ideas that they're starting to pursue. And I'm looking forward to assisting them in their implementation of that. So we have technical assistance that are needed to be able to help hospitals survive. But then we have the higher order thinking that we need to be doing around, getting to the higher levels on the Maslow's hierarchy of needs, trying to move upstream and help hospitals and communities basically deal with some of these issues. So I'm looking forward to working with you all and the groups that you all support, and how we can work together to make that happen.
You have been a terrific, clear, articulate voice for what is really needed in rural health.
Oh, thank you.
It's really a pleasure to be here with you.
Thank you so much for joining us. We really appreciate it. And the biggest opportunities in my life have been during those periods where there's been a lot of external forces and stress. And so
Well,
thank you
keep
so
me
much.
posted on your progress, and if there's anything I can do to help, I'm really glad to get to know you guys.
Thank you so much.
Thank you, Brock. To learn more about MTVA and how to join our community, visit our website at www.movingtovalue.org. If you enjoyed this conversation, please follow us and leave a review on Spotify or Apple Podcasts. Thanks again for listening and for being part of this important movement.